How's been your day, Dr. Waman?
Good, good. Not too busy. I fortunately don't have to do any of these COVID duties.
Um,
So
that's,
I only stick to my pediatric endocrine patients. So at the moment, there are less people turning up to the clinics.
uh,
So normally I end up seeing about 40 to 50 ped endo cases, but in the lockdown, I'm seeing about 10, 12, 10, 12.
yeah,
That's it.
it's really down. Pediatrics is really taking a big hit.
Yeah,
All of the departments are doing fairly okay. We are really struggling. So
correct.
none of the children, they don't bring children out, and they don't have any illness either.
Yes, yes. I think
Mm,
many more children would be carriers, but there's no way to know that really.
yeah. Not much serious illness in them.
Correct, correct.
So Dr. Varinder, when we had him, he was on COVID duty.
Oh,
Even
I see.
Sudhit was on COVID duty, so they were in a hurry to, you know.
Finish and go. Yes,
No,
yes.
but they stayed the whole length of 1.5 hours, 2 hours, and
Oh,
never
that's
went.
nice.
Then
That's nice, actually.
they were on duty. That was an issue. Parvati is also here. Only Riaz has to get in. You call Riaz?
Yeah, Dr. Pavadi, Dr. Narayanan, whether on the.
Riaz?
Good evening, sir.
Okay, let me see.
Good evening.
Good evening, Parvati.
Good evening, sir. Riya sir is joining. I've just sent him the link through mail. He couldn't enter. He's joining, sir.
Yeah. Hello, Abraham.
How's my audio? Is it clear?
Yeah. Your sound is okay.
Okay.
Can you speak, Abraham?
So how's the audio? Is it clear?
Very good. It's clear. That's fine.
Good evening, sir.
Good evening.
You're breaking up.
Who? Who's that breaking?
Is it
I think it's
Pramod,
my end. I think the problem is from my end because both of you are breaking.
Who's this? Both of you?
Narayanan sir, good evening.
He's just entered. Riaz is entering. Once Riaz enters, Ismail
No.
has come. Hello, Ismail. Good evening. Once Riaz gets in, then we can put everybody in. There's an IMA Day celebrations going on at the Doctors' Day celebration is going on at the IMA in Cochin.
I see.
Some of the pediatricians are stuck there.
So that is only at 8:30, 8:15, 8:30.
But they're all moving into IMA.
It's online.
It's Zoom, huh?
Yeah,
Okay.
yeah.
So major thing is the synapse that OSCE class is going on, the second session. That's a major chunk, you know. Lots of exam going. Students are going there.
That's a neurology.
Neurology, yeah, the second class.
Dr. Abraham Paulos. You have to unmute.
Unmute yourself.
Yeah.
yeah? Yes.
So everybody has shared their slide and see.
Yes, I have sent it to Jesus.
No, have you tried sharing it now?
Share it
No,
now.
not now.
Share
Can
it.
I do that?
Yeah.
Try that once.
All of you just try and share. Dr. Waman has shared?
Yeah, he's already done it.
Yeah.
Okay. That's fine.
Yeah, can you
Yeah.
see it?
Yeah.
Yeah.
Your
Please,
audio
Is my
is,
audio breaking
your
now?
yeah,
audio is is breaking a little better.
Okay, I'll just try the headphone then.
Yeah. Parvati, can you try your slides? Can you stop sharing? Yeah.
Yeah.
Yeah, fine.
10th ക്വിസിന്റെ
Pramoda.
മറ്റേത് ഹൈറ്റേജും വെയിറ്റേജും വന്നില്ല അല്ലേ?
അത് കുഴപ്പമില്ല സർ, അത് cut
കുഴപ്പമില്ല.
ചെയ്യാം. It's okay.
that's okay.
Okay.
Thank you, sir.
Welcome.
Sure,
അത്
sure.
ഒന്നുകൂടെ ഇത് കുറച്ച് ഇതായിട്ട് നിൽക്കുന്നുണ്ട്, പക്ഷെ അറ്റ്ലീസ്റ്റ്
It is much
കളർ
better.
മാറ്റിയിട്ടുണ്ട്.
Yeah.
Riaz is there?
Ria, I just talked to him. He said he will be joining in a couple of minutes.
Link email idu.
Just want to check my audio. Is this better?
Yeah, I think that's
it is
better.
slightly better.
Much better.
And
Can you talk some? Can you say something more?
yeah, good evening. I hope today's presentation will go on well.
But your video is also breaking up. The video is not.
Video,
It's not very smooth. It's breaking. And
there is a
then-
lag. Abraham, there is a lag.
Is it? Okay, let me just try it.
No, your video is not functioning at all. I mean, you can't see your lip movements at all. Maybe when you talk, it's better maybe that you off your video.
I'll do that, sir.
Narayan sir, good evening.
Good
Good
evening.
evening. Oh, it's the mask there. Huh? I thought you had a scarf on.
Opi.
Opia, ippendu opi.
Happy Doctor's Day.
Happy
Thank
Doctor's
you.
Day to
Yes,
all.
sir.
Good evening, data. നേരത്തെ വിളിച്ചത് കേട്ടു, പ്രമോദ് വിളിക്കുന്നത് കേട്ടു.
കേട്ടോ?
പേഷ്യന്റ് ഒക്കെ ഒന്ന് കൈകാര്യം ചെയ്യണ്ടേ?
എന്താ തിരക്ക് സാർ, എനിക്ക് വയ്യ. ഞങ്ങളൊക്കെ ഞാൻ 6 മണിക്ക് വന്നിരിക്കുകയാണ്.
മാസം കഴിഞ്ഞാൽ പിന്നെ 8 മണി ആക്കണം കേട്ടോ.
Yeah. No, from next time onwards, because they are stopping their 8:30 thing. Calicut is stopping the Wednesday program. The second week of July. So we'll make it 8 o'clock.
And Kerala, they were not holding any program next month.
Okay. We'll make it 8 o'clock. Next month is Raju Kupchandani and Suma. And they're doing rheumatology mainly. They're doing the case of dermatomyositis. Next is will be leukemia with Nitin Shah and all that. Riaz has not gotten us yet.
Sir, he had problem in his house, so he went to the hospital and he's trying from there.
My gosh, I hope.
He's here. He's here.
Is there? The first speaker.
Yeah, he's here, sir. He's just joining.
Once he joins, you can. Is there anybody? Yeah, he's joined.
So we have about 20 people in the waiting room now.
Yeah. Now once he gets in, you can send them in. Put them in.
Hello.
Yeah. Riaz.
Yes.
Okay,
yes.
fine.
Okay.
Nice to see you. We are
Hi,
waiting for you to come to before we put the others in. Meeting.
Okay, so I'm gonna admit.
Okay.
So we start in 3 minutes.
Yep. Hello, Dr. Vijay Kumar. Vijay Kumar. Nice to have you.
Hello, sir.
Nice to have you
Hi, sir.
here. Yeah. Your session was great, huh?
Which session, sir? That precocious puberty.
Yeah.
Total.
I think Parodi had all our PGs watching.
Yeah, sir.
Yeah.
I think we can have some more sessions like that.
Yeah, we should. Technology is looking up in a big way, pediatric endocrinology,
Yeah.
with all of you all here. And
Yes, sir. I think Riaz has joined.
yeah,
Yes,
this
sir.
joined.
Yes,
Everyone's
sir.
joined.
Hello, Riaz.
Hi, sir. So Vijay Kumar, good to see you.
Hello, sir. Hello, sir. Sir has joined, sir. How are you, sir?
I'm good, thank you. How are you keeping?
Yeah, fine, sir.
COVID situation not too bad.
So it is there still.
Yeah,
You're managing.
I know it's everywhere. It's quite rampant now.
Yes, I don't think within it will take few more months.
Every day, Maharashtra is adding about 5,000 cases now.
Yeah.
And mortality also is high.
Mortality, yes, and I think there is a huge underreporting. Huge
Much.
underreporting.
Not testing enough.
Yes,
Pune is better, sir.
Pune is better.
Pune is about 1,500 cases every day,
Oh,
but I think that is probably 1/10 of the reality.
Yeah. Chennai is also bad. Delhi is bad. They
Yeah.
are underreporting.
In private hospitals, they literally, a lot of physicians now say that we know you have got COVID, but we won't swab you. We
oh.
will treat you like COVID, but we won't let the administration know. So it's really bad, and the trend seems to be growing like that. It's very bad. In Mumbai, this is particularly true. Pune, it's not bad. Pune, the reporting is okay, but I think it is still about 80% only.
Mm.
Mumbai, I guess the reporting is hardly 50% or less.
And they're not checking the doctors also. What the
Yeah,
doctors
it's really, I don't know. I mean, the reality of any pan-endemic finally is that we have to develop herd immunity, but that might take longer than expected.
Shall we start, sir? 7 o'clock.
Yeah.
Yes, sir. All the best, sir.
Good evening, everybody, and welcome to another exciting episode of Pediatric Potpourri, brought to you by IAP Cochin Branch in association with IAP Kerala State. Today, we have a very interesting topic. I'm sure most of you would have had this question: is my child going to be tall? And to deliberate on this issue, we have a galaxy of eminent speakers. I welcome all, and over to Dr. Jason for the conduct of the proceedings. Thank you.
Good evening, everybody, to yet another session of Pediatric Potpourri. Happy Doctor's Day to all of you. I'm sure you all know that the theme for today is lessen COVID-19 mortality. So we are working towards that, and you all are all frontline workers. And today we have a very interesting session. All our pediatric potpourris have had thousands and thousands of people going onto the YouTube after the session is over. So we're going to have a very detailed session on growth monitoring today. And we have, as Dr. Pramod had just said, a galaxy of speakers to highlight the importance of growth monitoring and issues thereof. First of all, I'd like to invite Dr. Riaz. Riaz, can you share your slide, please? Dr. Riaz is going to talk about how short is really short. That is an issue that we all face in our OPDs. Can you put it on screen, please? And your next slide. So Dr. Riaz is the Associate Professor and Pediatric Endocrinologist at Trivandrum Medical College. Next slide. With your lovely photograph and the biodata, please. The next slide.
Shall I start, sir?
Your next slide. Your next slide has your biodata slide, no?
Right.
Yeah. That's what you're looking for. Riaz has got a fellowship in pediatric and adult endocrinology. He's the Associate Professor and Medical Officer, Pediatric Endocrinology and Adult Endocrinology. Nodal Officer, Mithai Clinic Newborn Screening Program, Department of Pediatrics, City Hospital, Government Community College, Trivandrum. Over to you, Riaz, for your presentation.
Thank you, sir. And thanks one again for Cochin IAP and Jason sir for this wonderful opportunity. And I'm very proud to share the session with our eminent speakers like Vaman sir. So being short is actually a question of perspective. So who is short? It depends upon where you are and how you are looking at it. But for doctors who are dealing with children, short stature is a very important problem. So there was a quest for a remedy for short stature from very long time back. We should all remember that, we will remember that there was once the cadaveric pituitary gland itself was used as a growth hormone, and that led to prion diseases, which led to loss of life in many. Then came the recombinant growth hormone. So short stature has been a problem for a long time, and now uh, we have to answer a few questions. What I'm planning to answer is the first three questions, which I have shown here. Are all short people abnormal? And why should we measure all children? And when and what are we supposed to measure? And whom should we treat and for what? The last question I will not, because my topic is on evaluation. So are all small children abnormal? So to answer this particular question, hello? Hello?
You're audible. You're audible. Continue.
Yes. Okay. So to answer this particular question, we can see some literature. So this is one study which was carried out on the North Indian population, North Indian children, and which shows that the normal variants, which include constitutional delay in growth and puberty, as well as familial short stature, amounting to around 60% of boys who are brought to the clinic for short stature, and 50% of girls who are brought are actually normal variants. So to begin with, we should know that children who are short stature, more than half of them, most of the time, are just normal. They are growing in their own genetic potential, or they are small as their parents, whom will catch up at a later date. But mind you, these normal variants can also surprise you. So you have to keep a follow-up of these children growth also. And another important point in this slide is we can see that a commendable percentage, that is around more than 10%. This is around 50, this adds to around 50 or 60%. Then another 10% is because of systemic diseases, which can include even simple anemia, even iron deficiency anemia. Then it could be a celiac disease. It could be other systemic diseases like a cardiovascular disease, a chronic respiratory problem. It could be a GI problem. So all those things should be thought of. And we can see in their study, actually, the growth hormone deficiency or pan-hypopituitarism are only negligible areas. So most of these children who are having short stature can be very easily evaluated as well as managed by pediatricians. But we should be on vigil to look out for the telltale evidences of serious endocrine conditions as well as other problems like a skeletal dysplasia, which we should find out and initiate on treatment. And if referral is needed, we can do that. So answering the first question, why should we measure? I will begin with the sad story of this girl who came to our clinic at the age of 16, and she wanted to grow desperately. But when we evaluate, all epiphyses are closed. The child is having a final height of 125 centimeter, and there is nothing we can do to help this child. We all know that once epiphyses are closed, there is no growth reserve available. So why should we measure? Because we know children has a window of growth which is unique for children. After a particular age, children can't increase in stature, and we know that closure of the epiphysis, the growth get arrested. There is no growth allowable after that. And we know, unlike layman, that most boys finish by 16 And girls, even earlier, their growth is finished, because there is a layman belief that children grow up to 18 years, 20 years. So when they say a child who is short, the people in the family will say, no, no, don't worry, you will grow after 15 or after 16, like that. So, but we know that. And we know there are conditions which we could help, like growth hormone deficiency, like Turner, who can be treated early, like simple conditions where an iron tonic can help in increase the height of the child, like hypothyroidism, where magical growth can occur. So all these things we know, and most parents don't know all this, and that is why we should measure. So all of us should make a habit of measuring children. And why should we measure? For this child, we will take an example of this particular child. So we asked them, so was she small always? The answer was yes, but her brother was also small and he grew later. So that is why they didn't go to a doctor. They didn't take it as a problem. It can happen. Anything medical we asked, so they're telling there was history of recurrent otitis media. There was some hearing issues, and she has thyroid. So we asked, what is that thyroid? So they had a report of the thyroid value, TSH value as 8, and the antibodies being positive. She was never on any um, thyroxine, and the T4 values were always in the lower half of the normal limit. And her periods at 16, she had not started having periods, but grandma told his mother that her mother also had late. So they were waiting. So all these mishaps occur because we also don't ponder upon the history of such children. So why should we measure? This is why we have to measure, because we need to measure, and only then we will know what it is. So you can look at where the child is staying. So it is like you can see that the child is way below the third centile as well as below the mid-parental height centile. The height, you can see that the height is already 125 centimeter, which is less than the third centile, very much less than the third centile, being the height age being 8 years. We can see that it's only half of the chronological age. The mid-parental height is 156 centimeter, which is between the 25th and the 50th centile. And weight is 51 kg, just above the 50th centile. So for this child, after the measurement, we know that height is more affected and weight is not that affected. So which points to an endocrine condition or a syndromic condition. If it was a nutritional problem or a systemic disease, we know that the weight will be more affected. So the weight would have been in the lowest centiles and height less affected. So this is how when we plot the measurements in a growth chart, just height and weight, we get a lot of ideas. We get a lot of information by just measuring and putting that in the perspective. The growth monitoring chart will be explained later by Abraham. And another saddening area was they had another measurement at 9.5 years. Somehow somebody had measured, maybe one pediatrician, and they were advised that this child is short, you need to look up. But they never did. And we can see the result at 16. Now the child had reached a plateau and we cannot help anymore. And when and what we are supposed to measure? At birth, at 6 weeks, at 10 weeks, at 14 weeks. All these are immunization visit. We have to measure the weight, length, head circumference of all children coming to us for immunization, and also at birth. And at birth, if possible, take an upper segment, lower segment ratio. Ensure that if in the male boy, in the male baby, the descent of testis has happened and there is no micropenis. And also look for ambiguous genitalia. This should happen at birth, because after that, it is very unlikely somebody will look at genitalia during a routine visit. Then at 6 and 9 months, 9 months again we have a immunization with 6 months also in IAP schedule we have an immunization visit. Otherwise also we can ask the baby to come for the weaning advices. Again measure weight, length as well as head circumference. At 18 months again weight, length and head circumference, another immunization visit. All these are very easy to practice. And after that growth monitoring should happen every 6 months thereafter. And also start beginning Tanner staging and record the findings appropriately. That means you have to use a WHO IAP combined growth charts 2015 to record the measurements, record the mid-parental height at the earliest available visit where both father and mother is there. And remember that the puberty timings is 8 to 13 for girls. That means if a girl develops breast before 8 years, or if she doesn't develop breast before after 13 years, it is abnormal. Either it is a precocious puberty if it is less than 8 years, and it is delayed puberty more than 30 years. And for boys, it is 9 and 14 respectively. And we have to do a Tanner staging. We should have such charts, and we should make sure that we do a Tanner staging in children, because it is not only for the adolescents. It should happen from an early age, because then only we will detect a precocious puberty. And also it should continue after the normal pubertal age, because then only we will detect a delayed puberty. For this particular child, we can see the breast stage is 2, the pubic hair stage was also 2, so the child is having delayed puberty. So this is a short girl child who is having delayed puberty. So what else to look at? So if there is underweight, we know it could be nutrition, infection, or SGA. So this child was 2.1 kg term, so she was a term SGA. There is no overweight as such. So if there is overweight, we have to think of conditions like hypothyroidism, Cushing's, growth hormone deficiency. Then pallor, there is mild pallor, it could be nutritional. Frontal bossing, midfacial hypoplasia are not there, but they indicate growth hormone deficiency as well as resistance. There is no hypertension. So hypertension is important to find out renal disease, which is a silent disease, which may not have any other manifestation other than maybe some pallor. There could be hypertension, short stature. So always takes some time to look at the blood pressure of children who are short. So it could also be a Turner who is having a essential hypertension or some aortic problem like coarctation of aorta, things like that. Then genitalia, always look, this child is having a normal female genitalia. So genitalia will tell you if there is a micropenis, it could be hypopituitarism, it could be a Prader-Willi syndrome. If there is a child who had progressed early in puberty, it could be a congenital adrenal hyperplasia if there is ambiguous genitalia, like that. And pubertal stage, if it is delayed, always think about Turner syndrome, then other causes of delayed puberty. So this child is having a delayed puberty, she's an SGA, and there is pallor. These are the positive findings we got. Then if there are any capsulospores, think about neurofibromatosis. If there is metacarpal shortening, again think about Turner, hypoparathyroidism. If there is a triangular facies, clinodactyly, think about Russell syndrome. Then we know the telltale evidences of Turner syndrome like increasing carrying angle, webbed neck, ptosis, strabismus, and also aortic abnormalities. All these were not there in this particular child. And also remember, there are typical dysmorphic features for children who are having Down syndrome, who will be having short stature. And then again for hypopituitarism, there could be a bifiduvula, there could be a single central incisor, there could be even there are conditions where you get a split epiglottis. So all these things becomes important in examination. Then bone age, we should not consider as an investigation. It is actually an extension of your physical examination. So we all were taught initially that bone age is equal to number of carpal bones minus 1 when you take an X-ray of the wrist, but that is not correct. What we have to do is we have to take an X-ray of the left wrist with hand AP view, and we should use a Grulich-Pite atlas or use the Tanner-Whitehouse method to find out what is the corresponding bone age. So bone age actually helps us in delineating the causes of short stature very much. Like we know that one of the normal variants of short stature is familial short stature, where the bone age will be equal to the chronological age. That means there is no delay in bone age at all. So if there is a delay in bone age, it could be a systemic disease, it could be an endocrine problem. And remember, the most delays in bone age occurs with hypothyroidism, then comes growth hormone deficiency. Delay in bone age can also occur in type 1 diabetes. It can also occur in rickets. So all delays are not. And there can be a normal delay of bone age up to 1 year. And in constitutional delay in growth and puberty, the bone age delay will be between 2 to 3 years. If the bone age delay is more than 3 years, we should always remember it is pathological. What else to measure? Other than the bone age, also look for a short metacarpal in all x-rays you get, because that could be a pointer to a Turner girl, that could be a pointer to hyperparathyroidism. And also there can be osteoporosis, which may tell you there is some vitamin D deficiency, and telltale evidences of rickets like cupping, fraying, and other changes of rickets. And thyroid evaluation can be taken in the first instance itself, because it is very easy to do, and also it's a very easy diagnosis to make and treat also. So that can be done along with the first line investigations, total T4, free T4, and TSH. Always do a calcium profile to make sure that we are not dealing with a problem of the mineral metabolism. So if you get a high phosphorus, always look at the creatinine also, because it could be a sign of renal failure. If you are getting hypocalcemia, then think about different types of rickets and other problems. Then always look for any sign of chronic inflammation. So do a complete blood count, a peripheral smear, and ESR. Urine for microalbuminuria or any albuminuria and other things. Microscopy also, any telltale evidence of a chronic renal failure. Blood urea, creatinine for ruling out chronic renal failure. Electrolytes to rule out a RTA, renal tubular acidosis. And if it is a girl and all tests are normal, always do a karyotype, because there are many children who are having no stigmata of Turner syndrome, but when the report comes, it is a 45X, and we will not diagnose them unless we make a very high index of suspicion. And SGOT, SGPT, I don't usually do as a routine, because if there is some evidence of jaundice, some chronic liver failure, we can do that. Then anti-TTG, that is the screening test for celiac disease. It also can be done in selective cases when the child is emaciated, when the child is having some abdominal symptoms, diarrhea, abdominal pain, along with short stature, we can do that. FSH is one helpful in detecting Turner, because in our hospital I have Shankar sir along with me, because most of the time if I ask for karyotype, I can get it within a period of maybe 10 days or 2 weeks, but it may not be possible everywhere. So if you do an FSH in a short girl, and if it is high, we can have a high index of suspicion for Turner syndrome. IGF-1 also can be used as a screening tool for growth hormone deficiency. But always remember, IGF-1 assessment has its own fallacies. Like in very young children and children who are having malnutrition, the IGF-1 can be falsely low. So it should be taken in the perspective of anthropometric parameters and other investigations. So this is one slide I want all of you to remember. This is a study done by Shankar sir, and it showed that the most of our Turner children, most of our terminal children, that is almost 50% of them, presented with amenorrhea to the gynecology OP, and they were not detected through our pediatrics department or pediatricians elsewhere. So this is one thing we have to always remember, that almost all of them came with amenorrhea. So we should have a high suspicion of detection for Turner syndrome and evaluate all children who are having short stature. And what are the other things we have to measure? Growth hormone studies should be done only in children who are having qualified for the anthropometric parameters. So if the child is coming early in life, what we can do is the most important thing, the most important pointer is a loss of height velocity. So if we can see the child in 2 visits, at least 6-month interval, and we see that the velocity is less, then there is high index of suspicion for growth hormone deficiency. If there are telltale evidences of growth hormone deficiency or hypopituitarism, then it is more easier. So, and always look for, before doing a growth hormone assessment, always look for other multiple pituitary hormone deficiencies. So always do a thyroid, make sure that your thyroid is normal, make sure your cortisol is normal, and then only embark on the growth hormone assay. And doing a single test of growth hormone in the morning is not the standard. It doesn't tell us anything. If it is low, that doesn't mean the child is having growth hormone deficiency. So always growth hormone test should be done as a provocative test after giving clonidine or insulin, whatever you take up. And MRI. MRI also should be done only in selective cases where you document a multiple pituitary hormone deficiency or even a isolated growth hormone deficiency. Or if you suspect some issues, there are some field defects, if you are having a headache or some telltale evidence of an ICSON, then we can go for a MRI. And genetic studies should also be pointed because it should be done only if we suspect there is some problem. We are suspecting a syndrome like Prader-Willi syndrome, some in Russell-Silver and things like that. So all these should come in the third tier of investigations. So this is one family which looks like a familial short stature because both the parents as well as the children are short. So this I am showing only because we should not label all short children who are born to short parents as familial short stature, because both of these parents were having growth hormone deficiency, which was of a heritable variety, and both their children inherited that. And now we have initiated treatment of the boy, and now the boy has been grown taller than the father. So this is something we have to remember. So this is my last slide. Measure the height of children on well and ill visits. Chart them in growth chart. It is very, very important. And only 30% of children with short stature has an endocrine cause. 70% is other ways. Always think about the normal variants, which are the constitution delay in growth and puberty and familial short stature before you embark on extensive test. And be in the lookout of clinical signs and never hesitate to do basic tests at your level. Thank you. Thank you, sir.
Thank you, Dr. Riaz. It was a great presentation of approach to short stature. I'd request you to stop sharing your slides, and I request Dr. Waman to share his slides.
Okay, shall I share the screen now?
Yeah, please. So we now have with us Dr. Waman Adilkar, who said that as under 5 mortality speaks of nation, health of the nation, a growth record speaks of health and disease of an individual child. He, in his publication, said that growth is the result of an interplay of many factors, including fetal programming, physiological processes in childhood, and environmental factors. He has done many studies on growth monitoring, and he has publications on about the Indian Academy of Pediatrics growth charts in 2007. You have the Indian growth references for height and weight and BMI. That's again in 2007. And the BMI cutoffs was also values were brought out by Dr. Waman Khadilkar. He is a consultant pediatric adults endocrinologist at Jahangir Hospital, Pune. and Bombay Hospital, Mumbai. He's past president of the Indian Society of Pediatric and Adults Endocrinology, the convener of the growth monitoring guidelines of the Central IIP 2007, 10, and 15. He's a convener of the calcium and vitamin D guidelines, Central IIP 2017. He's got his doctorate guide for Pune University, the Department of Health Sciences. So he is the editor-in-chief, was the editor-in-chief of Indian Academy of Pediatrics and textbook of pediatric endocrinology. He's had about 200 index publications in pediatric endocrinology, more than 300 presentations, 8 national and international conferences. So we have the speaker for the day, Dr. Vaman Khanilkar. Over to you, sir.
Thank you, sir. Thank you, IIP Cochin and Dr. Riaz and the team. Today, what I'm going to speak about is what is new in anthropometry. And as you all know, there are lots of new things that we have tried to do for Indian children and tried to establish some norms for Indian children. And although this is going to be a quick ride, I'll try to do justice to this. And then if time permits, I'll also show you a couple of cases. So Dr. Jason right at the beginning said that like the under 5 mortality speaks of health of a nation, a growth record for a child speaks of health and disease in that particular individual. And that's why traditionally growth charts are known as road to health chart. I mean, some of you who might have read a book called The Pediatric Priorities in the Developing World by David Morley. David Morley is considered to be the father of producing a road to health chart for parents. In fact, he was the person who actually, for the first time, educated parents to read a growth chart, to carry it to a health professional and ask questions. So we owe a lot to Professor David Morley. So moving on, please remember that as pediatrician or endocrinologist, anthropometry, that is measurement of body and its proportion and its parts, is an invaluable tool whenever you are assessing any abnormality of growth. Let it be short stature, tall stature, obesity, your anthropometry speaks a lot. To give you an example, in Australia, you don't need a growth hormone stimulation test to start growth hormone. All you need is anthropometric proof over a period of time, and you also rule out all other disorders, and then you can actually prescribe growth hormone. Such is the power and accuracy of anthropometry. All your tests can go wrong, but anthropometric measurements will not cheat you. Dr. Riaz has touched upon this. Which anthropometric parameters do you assess? So I won't read through the slide, as already told you, but I would add a couple of things to it as waist circumference in the diagnosis of metabolic syndrome, and skin fold thickness is also more of a research tool, but can be used even for large epidemiological surveys. So what are growth charts? Dr. Abraham is going to talk about it, so I'll quickly go through this. Anthropometric data collected over several thousands of children makes it possible to produce growth charts. Primarily, these are graphical representation of statistically smooth percentile values. They are commonly used to assess growth parameters. Tables used to be used. I remember in 1997 when I had just returned from United Kingdom after finishing my training at Great Ormond Street. I found some of the pediatricians in Maharashtra still using tables. They used to keep Professor K.N. Agarwal's tables under the glass of the tabletop, and they would refer to the tables for that specific age. But as you and I know, children don't specifically come to us at 9.6 or 9 or 10, 10.6 years. They come in between. So you need a continuous line. So always charts are better than tables. And remember, a single reading can trick you, but longitudinal data plotted over a period of time is far more valuable than a single reading is. Take birth weight and gestational age into consideration whenever you are interpreting anthropometric data. But also remember that you should stop correcting for prematurity after 2 years of age. There is no need to keep correcting for prematurity beyond 2 years of age. Now, the typical components of the growth chart are these. You have an x-axis, which is age in years or months, and y-axis is either height, weight, head circumference, or BMI. And the standard 7 percentiles are 3rd, 10th, 25th, 50th, 75th, 90th, and 97th. 50th percentile is the average, whereas the 3rd and the 97th are plus minus 2 standard deviations. BMI charts, however, are different. They don't have the standard percentiles. In WHO charts, you have a 85th and 95th percentile, or plus 1 and plus 2 Z scores. And in IAP charts, for Asian Indians, we have fitted the lines to 23 and 27 adult equivalent so that you have the appropriate cutoff for Asian Indians. Now, why do we have slightly lower than the Caucasian cutoffs? Because as an Asian person or an Asian child, we tend to have much higher body fat at a lower BMI. You also will come across some charts which are actually written in standard deviation score. Particularly the proportion charts are in standard deviation score. And I think a lot of you who are still in the pediatric training stage would have noticed that the WHO under 5 charts either come in percentiles or as Z scores. But what is important to understand and remember is movement of a parameter across 2 percentile lines is almost always abnormal. So it may be upward or it may be downward. In infancy, the time period you should give for the movement to occur is shorter. It's about 3 to 6 months. And at later age, it is 6 months to 2 years. Now, these are some examples of growth charts. So as you all know, the Indian Academy of Pediatrics produced its 5 to 18-year-old growth charts in 2015. And these are the charts for children between 5 to 10 years, 5 to 18 years, I'm sorry. So these are height records, these are weight records, and these are BMI records. Now they're color coded, blue for boys and pink for girls. Now, these are IAP simplified WHO charts. Now, what is the simplification? The simplification is that for ease of use, IAP has put 3 parameters on a single page. So you have length or height, you have head circumference, and you have weight for age. So if you download the WHO chart, then you have one chart for each parameter, and sometimes it is difficult to interpret them. And we have given you 4 percentile lines, the 97, the 50th, the 3rd, and the 1st. Now, why 1st? Because in India, a whole lot of very normal children actually fall between the 1st and 3rd percentile of WHO chart for length as well as for weight. These are not abnormal children. These are normal small children because we have got a smaller stature. To know whether they're abnormal or not, you then plot them on the charts which are seen on the right side of your screen. And these are weight for length charts. These are weight for length charts. And on these charts, we have given you 4 lines, the 99th, the 50th, the 3rd, and the 1st. And any child who falls below the orange line or the 3rd percentile is having MAM, moderate malnutrition. And any child who is below the red line or the 1st percentile line on these charts has got SAM, severe acute malnutrition. Now, please remember, in the WHO paper, WHO says that you can use SAM and MAM terminologies only after first 6 months of life. However, in real life, many pediatricians around the world would use SAM and MAM even before the 6 months. Now you have some disease-specific charts like Turner syndrome charts and Down syndrome charts. Now in India, since we don't have a registry for these disorders, we still do not have disease specific charts, but I'm working on it. And I think we should have a Turner syndrome chart published in about a couple of months' time for India. Next, we move on to the family adjustment of height. Now, you heard from Dr. Riaz in very elegant presentation that most of the time children's height would actually be largely decided by the parent's height. So it's called as the mid-parental or the target height. How do you calculate it? You add mother's height plus father's height plus 13 and divide that by 2 for a boy, and for a girl you subtract that by 13. This height is plotted at 18 years of age on the chart, and then you know what is the family target height. Then there is a target range. Now, if you look at about 20 papers written on mid-parental height, you would notice that the target range is given as between 6 to 9. For all those postgraduate students who are going to appear their exams, only remember number as 8, because Nelson textbook of pediatrics gives 8 centimeter plus minus as range. And why this difference between 6, 8 and 9 is because if you consider that the spread of children in a family is only 1 percentile around the mean, then it would be 5 centimeters. 1.25 SD would be 6 centimeters. 2 SD would be 8 or 9 centimeters. Therefore, this difference. But for PGs who are going to appear, say target height range is plus minus 8 centimeters below and above the target. In the IAP growth charts, we have mentioned 6 centimeters because we are not aiming at the 3rd and 97th percentile for the family, but we are aiming at 10th and 90th, 90 percentile for the family. So if you have to plot the mid-parental height, this is how you do it. Those two little red dots on the screen are showing the weight and height. And if you carefully look at the right side of your screen, there is an arrow, and I'll show that arrow with the mouse pointer. This is where you plot the mid-parental height. And then you would plot 8 centimeters above and below. So you get the mid-parental range. And then what you do is, from the bottom of the arrow that is pointing downwards, you would draw a line parallel to the 3rd percentile, and that would be the lowest acceptable limit for this family. Therefore, if you see this child's record, although he is on the 3rd percentile, for the given family, he is fine. He is actually above the lowest acceptable percentile for the family. This is the importance of having mid-parental height. However, Dr. Riaz very categorically and candidly mentioned that when you have got a family where one or both parents are extremely short, please do not rely on the mid-parental height alone. Now, a lot of people come and ask me this question, that India is in a state of economic and nutritional transition. A lot of parents have been malnourished as children. However, now with improved nutrition, don't we expect the children to be a bit taller than the mid-parental height? And the answer is yes. So there are multiple ways of calculating and correcting for mid-parental height. First one I told you earlier. The second one is you can use the father's height z-score and add mother's height z-score and divide by 2. It would give you a very similar result to the formula on the top. But then if you use the third formula, what is known as the corrected target height, you multiply the mean parental height z-score calculated by this formula by 0.72. So this corrects for the secular trend as well as for extremes of shortness and tallness. To show you an example, using the first formula, you get a mid-parental height of 162. Using the second formula, using z-scores, you get 162.0. And by correcting for the secular trend by multiplying 0.72, you get 166.5. So you correct for the secular trend by using this formula. This is Professor Tim Cole's formula for correction of mid-parental height for secular trend. Now, height velocity. You heard in Dr. Riaz's presentation that height velocity is a far more sensitive parameter of picking up abnormal growth. To give you an example, if you have a child who has a space occupying lesion, and before that occurred, his height percentile was 50th. So he was perfectly normal, he was not short. Then this child undergoes surgery, develops multiple pituitary hormone deficiencies, and when you see him next time after 6 months, he has only grown 1 centimeter. So when you plot his height, you realize that he is not yet short. But if you look at the height velocity, that is way below the height velocity norms. So we now have Indian height velocity. For all these years, we were using J.M. Tanner's height velocity charts, which are appropriate for Caucasian children, especially the English children, around 1970s when J.M. Tanner made the charts. But now we have Indian charts that we have published in Indian pediatrics. And as you can appreciate, they're a little flatter as compared to the English charts. So our children do get a beautiful growth spurt in puberty, but it is not as pronounced as it is in the Caucasian children. So I think we should now start using the Indian velocity chart so that we don't make inappropriate errors in height velocity assessment. This is your simplified height velocity. In the first year, you grow 24 centimeters, second year 12, third year 6, fourth year until puberty 5 centimeters per year. And then between pubertal years, anything between 8 to 12 centimeters, but I would go a little lower for Indian girls. They grow somewhere between 6 to 9 centimeters and boys somewhere between 7 to 11 centimeters. Now, a word of caution on using the WHO charts for Indian children. Now, you all know that obesity is increasing tremendously, and therefore, um, we had written this paper in 2010 in International Journal of Pediatric Obesity, and we showed that across Indian cities, the prevalence of obesity is as high as 18 to 24%. Therefore, we designed the IAP charts, and I mentioned it earlier that you have two lines. You have a 27 adult equivalent cutoff. So at 18 years, it reaches 27, just below 27. And these are the age equivalent cutoffs. So if you see here that, say, for example, a child who is 10-year-old, then your cutoff is only 15. So you have to use age appropriate cutoff based on the line. Now the orange line is overweight. The red line is obesity. Pink is for girls, blue is for boys. Now, I noticed that after designing these BMI charts from 2015, I did a short survey to find out how many pediatricians in the city of Pune and Mumbai actually plot BMI charts. And the answer given was their OPDs are so busy that although they want to, often they're compelled not to plot BMI chart because of time constraint. So what have we designed as a new thing? We have designed a quick BMI tool for the IAP growth chart, which is published in Indian Pediatrics last month. And see what the tool is. The tool actually is very straightforward. All that you have to do is between the age of 8 years to 15 years, this is for boys and this is for girls, you look at the height, say for example here, 150 centimeters in a boy, and then look at the weight. If a boy has 50 kgs with a height of 150, here you can quickly plot and say that, oh, this child is in the overweight range. If a girl child who is 150 centimeters tall and if she weighs 65 kilos, you know she's obese. If you have a girl who is 150 centimeters tall and weighs only 25 kilos, you can quickly look and say, oh, she's underweight. So this is a quick BMI tool designed for IAP growth charts published in Indian Pediatrics. And I urge you all to use this as a quick screening tool so that your time is saved. And we are publishing one more paper on this, and we found out that for a trained pediatrician to calculate and plot BMI, it takes average 25 seconds. But to use the BMI tool, it takes average 5 seconds. So most of us have 5 seconds for patient, and therefore this quick screening tool will probably help a lot of pediatricians who are very busy to quickly see who is obese, who is overweight, and who requires further evaluation. Now, you know that metabolic syndrome is increasing in children. Children older than 6 years nowadays are showing metabolic syndrome. This is the definition of metabolic syndrome, and the primary parameter is the waist circumference. Above 90th percentile of the NHA-NES charts, or wherever waist circumference is available for the given community and ethnicity, we should use a local charts. So we have designed the waist circumference charts for Indian children, which was published in the Journal of Pediatrics, the American Journal of Pediatrics. And these are your waist circumference charts. These are for girls, these are for boys. And again, they're age specific. They're to be used between the age of 5 and 18. And as you can see here, not the 90th percentile, but we are considering 70th percentile for Indian population as the risk factor. And that has been proved in a subgroup of patients. So don't wait until the waist grows to a point that it goes beyond 90, 95. At 70 itself, start screening children for metabolic syndrome variables. And now we have provided you with the Indian data. Then you have to look at children's proportions. Now, we have got Caucasian proportion charts. They're available for upper segment, lower segment. They're also available for sitting height and subischal leg length. Now, this data was missing from Indian children. So we have now published two papers, one in 2019 and one in 2020. And what have we done? We have given you upper body, lower body segment ratios from birth to 18 years for Western Maharashtra children. And then in a much larger study, we have produced national upper segment, lower segment, in the sense sitting height and subischal leg length chart for children of India. And anybody who wants to see proportions, I say don't really go for upper segment, lower segment. Please use sitting height and subischal leg length because it is far more accurate. What is important to remember is that if the discrepancy between the upper segment and lower segment is more than 2 standard deviation score, then you are looking at a disproportionate child. So the discrepancy should be 2 standard deviation scores. Now, for those who are in pediatric endocrinology or pediatricians aspiring for pediatric endocrinology often want to know what is minus 2.5 or minus 3 Z score on the IAP growth chart. And our IAP growth charts actually stop at 3rd percentile or minus 2 Z scores. So there is a definite need now to produce minus 2.5 and minus 3 Z score lines for deciding treatment of children who are small for gestational age or severe idiopathic short stature. And there are many similar conditions like Russell-Silver syndrome, etc. So we have now produced these lines for IAP growth charts. And as you can see here, the orange line is minus 2.5 SD and the red line is minus 3 SD for IAP growth charts. This is for boys and this is for girls. Anybody who wants to use it, please let me know. I'll send you the charts. Now, why do we insist on the IAP charts and not the CDC charts? I have shown you an example here. In the background, what you see, pink color is the CDC girls chart. And the 3rd percentile of the Indian girls is shown here as the blue line. And now see the difference. The difference is about 5 centimeters as they get older. So if you are going to diagnose idiopathic short stature using CDC charts, you are going to probably want to treat a very large number of normal girls and boys. A large number of normal girls and boys would fall between the 3rd centile of the CDC chart and between the 3rd centile of the Indian chart. So please use Indian charts. And therefore you will prevent inappropriate investigation and inappropriate treatment of a large number of children. Now the last few slides, I'm going to deal with something, a very novel technique called synthesizing anthropometry, and then I'll stop my talk. So what are synthetic growth charts? See, variation in human growth have been attributed to genetic, nutrition, and health. Still, human growth curves are remarkably similar. You look at an Indian growth curve, an American growth curve, a Chinese growth curve, they're remarkably similar. So the primary way of going about producing charts is that you create a very large global data set from more than 200 studies, studied humans over last 50 years. Once you have constructed that huge database, you design regression equations, which are formed based on the global data for determining the median for height and weight at all ages, only based on 5 key ages, and that is the beauty. So you only need data from 5 key ages. And then if you can collect data from a large country like India, just on 5 key ages, you can generate your growth charts. See, we did that mammoth exercise of producing IIP growth charts. That is collecting data of 86,000 children across this huge country. And that is cumbersome, that is difficult, that's very expensive. And the study runs for years together. By then, the children have changed. Whereas with this novel method, you just have to collect key ages means. And then what you do is from these medians, you can produce missing medians at all ages, and you can then use global LMS values to produce the growth charts. Now I have shown you in a nice little cartoon here. So what you do is you go across India and you can even take historical data of children at birth, at 2 years, at school entry at 6 years, 12 years for girls, 14 years for boys, and then at 18 years for boys and 15 years for girls. These are all the data points that you need and only the means. Then what you do is, using this data, you just plot them on an x-axis as points. Now, these are not charts yet. These are just your points. Now what you do is that you design regression equation based on the global growth of children. And using the regression equations, you actually create the growth chart for the missing points. It doesn't stop there. You have to smooth these points to the very time-tested model of Preece and Benz. So Preece and Benz models actually tells us the precise human growth curve. So you fit your prepared growth chart to the Preece-Benz model. And then because height is a variable that is normally distributed around the mean, you take global standard deviation and produce the local SDs at all ages. And then you get these beautiful growth charts. So you use the global standard deviation, fit it to the local means, you have prepared the median, and now you have the percentiles for height. What about the weight? As you can appreciate here, weight is not normally distributed around the mean like height. In height, the difference between each percentile line is the same. Whereas in weight, as you go up, the distance increases. So this is a skewed variable to the right. So you cannot use global standard deviation score. You need to use a formula using the least mean square or the lambda mu sigma method. And I have written the formula here. So you then use the global LMS values and produce these percentile curves. Same for BMI. You have the mean and then you produce these charts. And in 2019 December, very fresh paper, I have produced the 0 to 18 children's and adolescent growth chart using the LMS method as well as the synthetic method. And look at these beautiful new Indian charts. You can see them from birth to 18 years. And I believe that by using the 0 to 5 children on these charts and not using the WHO chart, we may be able to reduce the number of children who are actually normal but classified as stunted or wasted by the WHO. But that is just my hypothesis or speculation. We need a lot of field data to confirm before we can put the charts to use. These are the BMI charts. Now, these are some of the growth formulae for the PGs who are interested in knowing. Dr. Riaz and I'm sure Dr. Abraham and Dr. Parvati would be taking you through this. But these are the chronological age, height age, weight age formulae. And anybody who is interested can just go through this. If you have chronological age greater than height age, then weight age with mild bone age retardation, it's malnutrition. If the weight age is greater than height age greater than chronological age with mild advancement of bone age, it's obesity. If the chronological age is less than weight age, less than height age, and the bone age is significantly advanced, it's precocious puberty. And if your weight age is more than chronological age, more than height age, with significant retardation of the bone age, you are looking at endocrine obesity like hypothyroidism. I fleetingly mentioned that when you use WHO growth chart, this is just a word of caution that these are affluent Indian children across the country put on WHO growth chart and see the level of stunting and underweight that we still see in India with relative preservation of the BMI and weight for height. So we are normal, symmetrically smaller people on WHO growth charts. So my word of caution to all those who are involved in childcare is using WHO 2006 charts will lead to overdiagnosis of stunting, underweight and wasting and often an unnecessary referral. So use WHO charts, but the caution is that you may not have to refer at the third percentile, but refer below first percentile. And if a child is cruising between first and third percentile, then watch the trend for a longer period of time before you investigate or refer. There are lots of software tools for the clinician. You have the IAP growth chart tool. This is free for Android and iPhone. You can just download it from the stores and use it. No registration is required. And this actually produces the growth chart for you. It even interprets for you. In a busy OPD, these are very helpful. It tells you where the weight is. It tells you below -3. It interprets for you. And for those who are doing the postgraduate thesis or research, I have produced a number of spreadsheets like this using the Indian data. And here, if you enter your patient's age, gender, height, and weight, I have got templates for blood pressure, BMI, and all those that you require. And you get the Z-score straight away here. And you can get 5,000 children at one go. So your thesis or your research can be very easily done. Now, I don't think I have time for showing you any examples, so I'm going to stop here and I'll take away just 1 second.
I think you can show some examples.
Should I show some example?
Yeah, sure.
Just 1 second, I'll share the screen again. Okay, so I'll take you through a couple of examples, and I think the most exciting one is this one. So you have a 5-year-old boy whose height is 120 centimeters and weight is 17 kilos. His target height is 165 centimeters, and I've plotted the target height percentile here. And you have his height percentile here and weight percentile here. Now, this is how you mark the height age and the weight age. So you draw a parallel line until it meets the 50th percentile and draw a perpendicular and read off the height age. Now here you can see at 5 years, this child's height age is 6.7 years, but his weight is already on the 50th percentile. So his weight age is 5 years. So putting it in a formula, you see height age more than weight age equal to chronological age. And then this child's bone age was actually 10 years. So if you plot a bone age here, it will go across here. So you have a child who is not overweight, but tall for age, much taller for the family percentiles, and his bone age is significantly advanced. You also notice he is hyperpigmented. And when you carefully look at this boy, he's hyperpigmented. He has an adult size phallus and very small testes. So his testosterone is not coming from the testes, but it is coming from adrenals. So this is a typical case of simple virilizing type of congenital adrenal hyperplasia. So now I'll go directly to, and might show you one more example actually. Here is the kid that you can see in this picture. This is how her growth chart was. Over a period of time, she descended on her growth chart with a low growth velocity, which almost became stationary. However, her weight was going up and up. And what you find here typically is a child who is short, overweight, with infantile body proportions, a protruding belly, and her TSH was more than 100, a case of primary hypothyroidism. So my concluding slide, I'll straight away go to summarize what I said in my talk. Growth charts are an invaluable tool in the hands of a pediatrician. Please get into a habit of plotting growth until the age of 18 years and don't stop plotting at 2 or 5. Growth charts help to reduce expensive investigation. Use the IIP modified WHO charts for under 5 children and IIP charts for 5 to 18-year-old. Many new Indian anthropometric data, as I showed you today, are now available, and please use them. We have a textbook on pediatric endocrinology. The Indian Academy of Pediatrics has written a textbook. For those who are interested, can get it on JP Brothers website or on Amazon. Thank you. For those who are interested in getting any of the templates that I showed, please write me a mail at vamankhadilkar@gmail.com and I'll ensure you give you the template. There's no royalty or no charge. I have kept it free of charge. Thank you.
Thank you, Dr. Vaman Khadilkar. It was an excellent presentation. You've done so much of work in the area and you're continuing to do it. And we are so happy that you were there for the PGs. They really learned a lot from your presentations.
Thank you, sir. Thank you.
We'll now go on to the next presenter, that is Dr. Abraham Paulos. Abraham, please share your slides. Well, he's going to talk about deciphering problematic growth curves. This is something that we'd all like to hear about. Dr. Abraham Paulos did his MBBS from Kasturo Medical College, Bangalore, and his MD from Christian Medical College, Ludhiana. And he did his MRC PCH from UK and is a postdoctorate fellowship in pediatric endocrinology from Indira Gandhi Institute of Child Health under Dr. Raghupati at Bangalore. He is currently the Associate Professor of Pediatrics and Pediatric Endocrinologist at the MOSC Medical College, College. Over to you, Abraham, for your
Thank you, Jason, sir, for that kind introduction. I hope I'm audible.
Wow.
Yeah, I've switched off my video because I'm having some problem with the internet. Respected seniors and dear friends, growth monitoring is an art. A robust growth record, properly interpreted, is reassuring, whereas an abnormal growth pattern may be an early warning of a clinically significant but as yet undiagnosed condition. So today I would like to address the guiding principles of growth monitoring that apply to all growth problems and discuss the most common growth curve deviations and also approach to their management. The evaluation of a child suspected of having a growth problem is guided by answering the following questions. The first question I always ask is whether the child's growth is normal or abnormal. And this requires accurate weight and height measurements, and not just weight alone, weight and height measurements taken serially and compared to national standards as a child's peers. The second question is the child's growth within the range for the family? And of course, this involves measuring the mid-parental height, and you have to compare it, or you have to see this in the potential of in the light of genetic potential. And the third and the most important question is a child's growth velocity impaired. And this can be accomplished by comparing the current height of the child to his own prior growth record or the growth pattern. So you could think of them or remember these as a 3 P's of growth philosophy. And to have a good growth record, it is mandatory to get your technique and also your, you should have the proper instruments, a proper stable wall mounted device or an infantometer, and consistent record keeping. Now, once the weight or the length or the height and BMI is obtained, it should be plotted on appropriate validated growth charts. And as Vaman sir has rightly pointed out, the revised 2015 IAP charts are now the recommended growth charts for children from 5 to 18 years. Whereas for younger kids, less than 5 years, the WHO charts are recommended. And it's such an honor to have Dr. Vaman with us tonight. He's a creator of the IAP growth charts. And sir has also told us about the combo, the IAP and the WHO. And for all practical purpose, we'll have to just use the combo charts, the IAP and the WHO charts right from birth to 18 years of age. Now, let me take you through also the preterm charts. The intergrowth 21 charts are now recommended. Apart from that, you can also use the Fenton charts. Now, let me take you through some prototype growth curves, which we'll go through them, and also let's work them together and also think about arriving at a logical diagnosis. This is a 5.5-year-old boy who was born at term, whose birth weight was around 3 kg. He was absolutely no postnatal problems. And he was exclusive breastfed till around 6 months of age. And then the mother started using milk as a weaning diet. And also, since then, the child has been having chronic diarrhea. And subsequently, the child has been failing to thrive. He's right now on milk and wheat restricted diet. And apart from that, there's no family history of any chronic illness, and there were no symptoms of any respiratory or renal problems. He was taken to a gastroenterologist, and the gastroenterologist suspected an endocrine problem. He did a TTG, which was normal, and because of low IGF-1 and growth hormone, the child was referred to the pediatrician. And as you can see on examination, he's got pallor, he's got clubbing, pan-digital clubbing, but and also no icterus. He's got his abdominal distension and also bilateral genu-valgus deformities. Systemic examination otherwise was normal. As sir has already pointed out, it's easy to now just plot it. We'll have to just take his weight. His weight is around 100 centimeters, and you have to get the date of birth. So you have to plot it at the exact chronological age. And the height is around 100 centimeters and weight is 12 kg. So now you can see that both of them are less than third centile. You have to take the mid-parental height. So the average of both the parents, 170 plus 155 by 2 plus 6.5 being a boy. And you can plot it using an arrow. Plus 6 and minus 6 would give you the target height range. So you could see that his height and weight both are less than third centile, and his height is less than his genetic potential. Next, you can calculate the weight age and also the height age. Now, the height age of a child is the age at which the corrected height becomes 50th centile. So you could you can see that, you can just draw a horizontal arrow till it reaches the 50th centile and drop a vertical, and that would give you the height age and also the weight age. So if you interpret his height age, it's 3 years and 6 months, and weight age of 2 years. So substantially, the height age is clearly substantially lower compared to the weight age is substantially lower compared to the height age. Now, with this case scenario with GI problems and also having anemia and rickets, obviously malabsorption needs to be ruled out. But unfortunately, fortunately, you need to realize that the mother, who was a teacher, she had understood the importance of monitoring weight and height, and she had kept a perfect record. And all I had to do was plot all these on the growth chart. And if you could just interpret this, you could see that the fall of you can see the weight loss, so the weight centile loss precedes that of the height centile loss. So the child showed a deceleration in the weight gain for several years before his height was affected. Now, such a pattern should stimulate both a dietary and GI or renal evaluation. No endocrine growth problems would show such a pattern. So the screening tests were done, and most of the screening tests are basically to rule out renal problems, would include a renal function test, a serum creatinine and electrolytes. And in this child, especially, you have to do a TTG and a stool for fat cells. Now, his HB was low, 9.6, with an elevated ESR. His albumin was also low with a normal liver function test. His calcium profile was normal. The endomysial IgA antibodies were also negative. And the stool for fat cells were negative, and the ultrasound came out to be normal. So is our growth pattern wrong? Is there something more to it? Are we missing out on something in this child? But I think a simple investigation clinched the diagnosis. The peripheral smear showed acanthocytosis, and ophthalmic evaluation had shown retinitis pigmentosa, and his cholesterol and triglycerides were very low, clinching the diagnosis of A beta lipoproteinemia. Where the take home, the lessons which you have to learn is whenever you feel that the weight centile is much less than the height centile, and this has been already told to you, you should need to think of a nutritional or a secondary due to a chronic disease. And IGF-1 is low in malnutrition and absolutely no role for a random serum growth hormone level. And the pattern of growth or the height velocity is the key in evaluation of abnormal growth records. Now, this was a 14-and-a-half-year-old child. The family seeks evaluation for short stature. And you can see that his height and weight were less than the third centile, but otherwise he was healthy and active. And the physical examination was absolutely normal. His mother had attained menarche at around 14 years. His height was less than third centile, and you can see that the weight was on between the first and third centile. His weight, his height was less than the mid-parental, the target height range. And you could see the height age was around 10 years and 6 months, and weight age of 10 years and 8 months. Now you need to realize that born age is an extension of examination, and his born age had shown it was 12 years. And you need to realize that anything more than 2 years is abnormal. So a delay of 2 years would probably be seen in constitutional delay in growth and puberty, and also some of the mild chronic illnesses. Born age should be represented by either a cross or a triangle. You can see that that's his born age. So to interpret the clinical picture, this is a kid who was 14 years and 6 months with a height age of 10 years, 6 months, and a weight age of 10 years and 8 months. His height is below the MPH and a born age of 12 years. And a little digging further in the history showed that the father was always, he was very small. He was a late bloomer. Sometimes the postgraduates are always, more worried about the mother's menarche, and sometimes the father's growth is missed out. And most importantly, the Tanner staging showed that he had no pubic or axillary hair, and the testicular volume was just 3 to 3 ml bilaterally. So unfortunately, we didn't have any previous height records. A chronic illness workup turned out to be normal, and it was decided his thyroid function test was normal, and it was decided to follow him up. And you could see this pattern is very classical of constitutional delay in growth and puberty. This is a somewhat similar growth chart. You can see the height centile has always been on the lower centile. It's just below third centile. It's always been parallel. And you can see, but the height centile the height is within the mid-parental height. So this is quite classical of a familial short stature. So what both these case scenarios teachers is that the family growth and pubertal history are very valuable. And more importantly, you have to think of not just the weight alone, you should always be interpreted in the height of the genetic potential. Also SMR, I think pediatricians should at least know a testicular volume of at least 4 ml and also 15 and 20, or at least 20. So this is extremely important. And the born age, you need to realize that born age is very crucial piece of information. And if it is something which probably there's some learning curve involved, but if you can learn how to interpret a proper born age, it will be extremely important and useful in your clinical practice. Next is an 8-year-old girl, 8.5-year-old girl. And their concerns were that the mother felt that the child has not grown in the last few years. Her father was short, and the mother always used to taunt saying that like father, like daughter. But when you can see the younger sibling started growing older than or taller than the elder sibling, that's when mother felt that something was wrong. Examination, she had no stigmata of Turner, and otherwise she was a prepubertal status, and other examination was normal. Now you could see that growth was plotted. Height is between the 3rd and 10th centile. The weight was between 50th and the 75th centile. If you look at the growth, the mid-parental height, which was 148.5, and the target height. Now, this growth curve seems to be normal, isn't it? The height is well within normal limits, and also her height is also within her genetic target range. Even though her weight is somewhat excessive for heights, nothing seems to be amiss. And also you need to realize that fortunately we had this is a weight age and height age. And fortunately we had two records before the child entered the preschool, the school time. And if you could, now the picture changes, you could see that a height centile from around to 75th to 90th centile has gradually moved over to the third centile in the previous few years. Her growth, her born age was just 6 years, there was a delay in born age. And obviously this thyroid function test was done, which showed a low free T4 with a TSH of 380, and the antibodies were positive, 1000 international units per liter, making a diagnosis of Hashimoto thyroiditis. Now, this is a problem with single height measurements. There's no growth pattern to see. But if you follow up this child over the years, you could, this classical, and I think Vaman sir has also shown this in the last growth chart, this classical where there is altering of the height with a gain of, you can see that the weight crossing the centiles. And this is very classical of an endocrine problem. And you always need to rule out an endocrine disorder. So the last two scenarios, what we have seen is if the height is much more affected than weight, you need to look into the growth velocity. And if the growth velocity is normal, you need to think of normal variants of short stature, either familial or a constitutional delay in growth in puberty. Whereas with a subnormal growth velocity, you have to rule out endocrine disorders. This was a 12 and a half year old boy who had come with the parents had brought him with saying that he's not grown in the last couple of years. They were concerned about his height. And this was the family, you can see that compared to the elder sibling, he is not grown at all. And also the child was very depressed because most of the kids were counting him at the school, at his class. And this was you could see his height and weight. And this is quite alarming, isn't it? And you need to realize that as pediatricians, our priority is not to just pick up short stature. We have to pick up the kids much before they come to this stage. And you can see that he's way below the mid-parental, his target height range, and his height age and weight age. Height age is just 5 years and 3 months. And this born age was just 8 years. And obviously this would this prompted us to think of growth hormone deficiency with such a delay in osseous maturation and his height way below his target potential. And the growth stimulated growth hormone after sex hormone priming, it came as 0.2 nanogram per ml. And you could see his MRI showed the classical triad of a anterior hypoplastic pituitary with a Stog abnormality and an ectopic posterior pituitary. And he was started on growth hormone, and you can see the improvement in growth velocity after he was started on therapy. So what you need to realize that you need to recognize short stature even much before the child presents to you. And that's where the growth velocity is going to help you. And to diagnose a child with growth hormone deficiency, you have to look into the clinical, oxological, both biochemical and radiological in totality and never in isolation. And obviously optimal growth hormone therapy is life-saving for such kids. And this is the last scenario where an 11-year-old child was brought with the complaints of being shortest in the class. She was always short for her age. And she's had recurrent otitis media. Apart from that, her physical examination was normal. She had multiple nevi, and her pubertal status was pre-pubertal. And you could see this growth chart. Actually, we've come a full circle. And this was a growth chart, which is somewhat similar to the growth chart with Dr. Riaz had projected first. You could see her height is less than third centile, way below her target height. And you could see the height age is just 7 years and 5 months. Her born age was normal. So any short girl, you need to always think of Turner syndrome. And this is a growth specific chart where you can see that compared to the normal population, how it differs. And you have to, once you confirm or doubt that a child has got Turner syndrome, you should always do a karyotype and a basic screening test involving a thyroid function test, echo, and an ultrasound abdomen and pelvis, maybe an FSH at this age, 11 years. An ophthal evaluation and also an audiometry evaluation is mandatory. And the only takeaway message from this kid is to think of Turner syndrome in any short girl, irrespective of the phenotypic features. And you have to start growth hormone therapy as early as possible for a better final height. So beware of, we've covered almost all these situations where we've seen kids, you have to pick up all these kids with severe short stature where the height is way below the parental height and subnormal growth velocity of this crossing of height centiles when there's disproportionate short stature or dysmorphic features and a retarded born age. So let me summarize by saying that a thorough history, a meticulous physical examination, including pubertal assessment and born age, together with just comparing three components, the child's age along to his peers and to his parents and his also pattern, is going to give you much more information than all the lab investigations put together. And you need to realize that the comparison of prior pattern of growth is the most important of the three. And this can be only done if you have a well-maintained growth chart. And let me summarize with one of my favorite quotes, that knowing is not enough, we must apply. And willing is not enough, we must do. Thank you so much and hope you've all enjoyed it as much as I've enjoyed presenting this to you. And let me acknowledge my teachers, Redpati sir, Piyasan Menon sir, Bhatia ma'am. And also my thanks to the Kerala Pediatric Endo family, seniors and also colleagues at Kolanjeri. And last but never the least, the Trimurtis of IAP Kochi, Jisan sir, Joni sir, and also Pramod. Thank you.
Thank you, Dr. Abraham. It was an excellent presentation. We'll go to a few questions. I think there's one question from somebody who I don't know, she hasn't given her name. Says, if you're following up a child from infancy, the growth, when do we really start investigating this child? Dr. Aman?
Sorry, can you please repeat that question?
I don't know, it's a vague question. She said that, you see, if you're following up a child from infancy, when do you when you press the alert button? When do you start investigating more or the child?
Okay, I think if you have got a very young child, your growth is not really going to do much because growth hormone deficiency can present even at birth. But usually then it's part of multiple pituitary hormone deficiencies and things like diabetes insipidus would actually present first. However, if you're following a child from infancy and you find that the growth failure has started occurring in the later half of infancy, I would first concentrate on chronic disorders such as renal tubular acidosis before moving on to anything like endocrine. And again, plotting on a growth chart for which is the most severely affected parameter would guide us towards the diagnosis. It's more again to do with length, weight, and head circumference and weight for length. That should guide us whether it's an endocrine disease or chronic disease or which way we should go. That's how I would look at it.
Another question, Dr. Aman. See, the health services in India, has it overcome the concerns of lower participation rates, poor health worker performance, and inadequacy of health system infrastructure in growth monitoring? What is done? See, you've got charts, but is this applicable for the health sector? Do the Anganwadi workers or are they able to do this? See, even for us, for pediatrics, finding it difficult to understand what you're saying.
Yes, indeed. I mean, I think Anganwadi workers have all got the WHO growth charts now. They do plot children. However, the referral rate gets so high, as I said, that nearly 60 to 80% of all children in the rural sector and 30 to 40% of all children in the urban sector will have to be investigated. And now that is one area, that's why this synthetic effort of synthetic growth chart, that we ought to have a two-layered assessment of the children. What is being done, I think these people are actually asked to refer or to improve the nutrition. But I do see parents who are actually scared because every now and then the health worker, the Anganwadi worker goes and says, your kid is malnourished, we need to admit your child. So literally patients tend to run away because their child does not have a disease. I think we are using a wrong scale. to measure rather than using an appropriate scale to measure. But it's something that we as pediatricians will have to take further with government, because there's so much pressure from WHO to use a single growth chart across the world. I think India has agreed. But I'm sure all of you who are listening to this would agree that if we start investigating all those who are below third percentile for height, weight, or weight for height, we will end up investigating 60 to 80% of children who are normal. So hopefully we will be able to make a case to the government saying that we ought to have a two-tier system. First is use WHO charts. That's fine because it's a single scale across nations to know where all children start in a given country. But when it comes to referral, I think we may have to, as Indian Academy of Pediatrics, provide one more chart that if they're below this, then only refer. But we need to field test that. And that's where I'm waiting. That synthetic chart has just come out. The more people field test it, the better information we will have.
It'll take some time.
It will, certainly. Yeah. But I think
What
it will be a step in the right direction, actually.
Yeah, this you were someone is talking about of celiac disease. You know that the disease, you know, you could detect it much earlier, many years earlier, if you had plotted their growth charts. What is your experience in that?
Actually, it's true. In fact, many celiac children will only come with growth failure way before the anemia or the pot belly has come up. So yes, we can detect, and in fact, that is true even of space occupying lesions. Growth failure can be the only symptom of intracranial space occupying lesion. So growth monitoring will tell us months or years before the disease is manifest. So that's true. Celiac is a classic example.
Another question is, do you have, see, there are certain growth charts for cerebral palsy, which are, you know, growth, their general motor function, depending on the general motor function. Is that reliable? See, there are questions from the development pediatrics chapter that we see. We follow some growth for Down syndrome. There is a growth chart, I believe. But what about for cerebral palsy?
We have no data from India actually on that, but those disease specific growth charts which are published, I mean, there are growth charts even for SGA children now. So, but they again are all Caucasian data, so we have to use them with caution in our country. But yes, there is no harm in using them as long as they monitor it at a regular basis. And once again, the trend will be important. They are authentic charts. They're um, published by authentic websites. So I think they can be used. But the general idea is when you are using a disease specific chart, unless there's a reason to use disease specific chart, don't use it. For example, children with cerebral palsy have a lot of problems with nutrition. They have lots of problems with reflux. They have osteoporosis. Their muscle mass is less. But that doesn't necessarily mean that we should plot children with cerebral palsy on a CP chart. I would rather plot them on a normal chart and try to normalize their growth. But for Turner syndrome, it's a different story. You're looking at a syndrome. For Down syndrome, it's a different story. Okay. But for other disorders, I would be cautious.
And what's your opinion about computer-guided population-based screening systems?
About, sorry, what?
Computer-based, computer-guided, you know, population-based screening systems for growth disorders. Computer-based. You know, will that be useful in for the?
I think artificial intelligence is now acquiring such high skills that it's difficult to predict. But I guess in time to come, it will be a very, very useful tool to guide us as clinicians. Like, you know, for genetic syndromes now, so many geneticists are actually using these databases to narrow down on what they're looking at, and then only ask that specific genetic test. So I think, yes, there is a definite role of that.
Because there are studies on Noonans and Prader-Willi and Silver-Russell and all. They have this computer-based.
I agree. I think they're useful in time to come. And probably some of them are useful now also, actually.
There's a question for Dr. Riaz. How do you select patients with short stature for endocrine evaluation? Is there any criteria?
Okay, like as I have told, the first thing what we have to do is we should plot the height and weight in a growth chart. And as in many cases, which Vaman sir had shown and Dr. Abraham had shown, we can see that when it is an endocrine problem, the most affected area will be height. Like height will be affected more than the weight. If you are having a child whose weight is not affected, but height is progressively affected, then that is the case you have to think about an endocrine issue. It will vary from different types of cases. If it is a Cushing syndrome, you will see the child is becoming obese. For a growth hormone deficiency, usually the child will be chubby. The child may not be obese, but the weight will be in the higher centile, and the child will be having a short stature. So the most important thing is that. And regarding hypothyroidism also, there could be, the child could be a little chubby, height can be in the upper centile, weight can be in the upper centile and along with the short stature. So that is how you choose children for endocrine evaluation. But even though for all children who are short statured, I will recommend we run a thyroid function test because it is easily available and very easily treatable disease.
Okay, there's one question by Dr. Latika on Prader-Willi syndrome. How can you diagnose if the child is showing increased weight and the same height? Is there a way to diagnose it? I don't understand what she's asking, but that's what she said. You want to answer that? Prader-Willi, I mean, you have other features that you will look for. Dr. Abraham, there's one question. Key challenges faced by pediatrics in growth monitoring. We all have problems with growth monitoring. What is the key challenges that you think?
One of the commonest excuse which I hear is being a busy OP. Probably you cannot take both height and weight as a routine scene. But and also probably our growth charts are underutilized, and also the interpretation may be lacking because there's no height velocity to see, because there are very few serial plotting occurring on a day-to-day basis. The born age interpretation, I understand, is also a major concern because we need to have some learning regarding, and carpal, you have to get out of that looking at only the carpal bonds, because beyond infancy or toddler age group, carpal bonds are not useful. You have to look at the metaphyses and also the epiphyseal centers of phalanx and distal phalanx. So that way, probably some training is required there. And another major problem, I think, is the SMR. The Tanner staging is not done on a routine, maybe the busy OP, and also there are other issues of privacy. Maybe that's why. And maybe, yeah, we rely too much on lab investigation, when a growth chart would be more than enough just to, and majority of the cases are usually a normal variant of either the familial short stage or the constitutional delay in growth and puberty. But just getting that height velocity and a born age is all that is required, and getting a normal growth velocity or the height velocity, the pattern, is all that is required. So these are, I think, some of the challenges which I feel that these are faced by the pediatrician.
Yeah, Dr.
Thank you, Dr. Abraham. Now we'll go on to the pediatric potpourri quiz, which is going to be run by Dr. Parvati. She's a consultant pediatric endocrinologist at Aster Medcity, Kochi. Next slide, Parvati. Dr. Parvati, please. And she's done a fellowship in pediatrics and adult endocrinology along with, I think, Riaz and Dr. Ragupati at IGICH at Bangalore. Her after MD from Trivandrum, and DCH MD were from everything was from Trivandrum. She is now the consultant pediatric endocrinologist at Aster Medcity. Parvati.
Thank you, Jason, sir. Good evening, all. So I'll quickly take you through the quiz. The quiz is mainly intended for postgraduates, but I'm sure all practicing pediatricians will also have fun answering this. So the answering pattern, as Dr. Pramod was mentioning, you can answer with the number of the question. Question number 1, if it is A is your answer, put it as A. So postgraduates, please answer in the chat box. So the few questions would be from the Dr. Riaz's session. What are the clinical clues to identify a short child? And few questions from the anthropometry and the growth chart. So the first question, this is a 15-year-old girl who has come to your OPD with short stature. And this child was asked to make a fist. And you see an important finding here. And seeing this finding, we have ordered an X-ray hand. X-ray, both hands were taken. There are significant findings in both of these. And my question is, where do you find these signs? List the possible etiology of this sign: pseudo-hypoparathyroidism, Turner syndrome, normal variant, all of the above. Your time starts now. 10 seconds is the time. Postgraduates, please answer.
Please put 1A or 2A like that. Don't put A alone.
Can I move to the second question?
Yeah. 10 seconds. So
this is the second question. This is again a 7-year-old boy with short stature. There is a significant history of a recurrent hypoglycemia in early childhood. In the oral cavity, you have found out a significant finding. And what does this finding point to? All these are causes of short stature. Out of this, what does this finding point to? Russell-Silver syndrome or the Silver-Russell syndrome, hypopituitarism, Rubinstein-Tybee syndrome, Noonan syndrome. So put question number 2 and the answer. Seven-year-old boy with short stature, history of recurrent hypoglycemia. This is a clinical clue to the etiology of the short stature. What could be that? Russell-Silver, hypopituitarism, Rubinstein-Tybee, Noonan syndrome. Moving on to the third question. This is an 8-year-old boy with short stature. He was born term. His birth weight was 2.1 kg. There is history of significant feeding difficulties. You find a little bit of facial abnormalities, which includes a triangular facies, a small jaw, and you can see the clinodactyly bilaterally. So what is a clinical diagnosis based on the history and clinical findings? Noonan syndrome, Cornelia-de Lange syndrome, Russell-Silver syndrome, Seckel syndrome. Your time starts now. Put the question number and put the answer. So term baby, birth weight of 2.1 kg, feeding difficulties with triangular facies, small jaw, clinodactyly. If you're done with the answering, I'm moving on to the fourth question. This is from the anthropometry section. The constant which is added to parent's height in mid-parental height calculation is A, 10 centimeter, B, 12 centimeter, C, 13 centimeter, D, 6 centimeter, E, 2 centimeter. Please put question number 4 and the choice you would like to opt. I'm moving on to the fifth question, again from the anthropometry. Third percentile in the growth chart is equivalent to dash is Z score, -3 Z score, -1 Z score, -1.86 Z score, +2 Z score. Put question number 5 and the choice you are opting. Moving on to question number 6. At birth, the upper segment to lower segment ratio is dash. A is 1, B 2, C 1.7, D 1.3, E 0.9. Your time starts now. I think this would be easy for all postgraduates, and I am moving on to the 7th question. The height velocity below the following percentile is abnormal. Third percentile, 10th, 15th, 25th, 50th. 10 seconds. Please put the question number and the answer and the choice. Moving on to the 8th question. These are questions based on the growth chart interpretation. This is a 10-year-old girl who has come to your OPD with excessive weight gain and lethargy. On examination, there is no dysmorphism. She has already come to you with a thyroid function report, which is commonly ordered while you are evaluating an obese kid. TSH is elevated, 8.9. Free T4 is 1.5 nanograms per DL. The thyroid antibodies done are negative. There is no goiter. So there is excessive weight gain and lethargy. I'll just quickly take you through her growth chart. You can see the weight is above 97th centile. This is the height plotting. You can see it is in the 90th centile. This is the pink chart, IAP chart for the girls. And you can see the mid-parental height is somewhere between 10th and 25th centile, and she is in the 90th centile. And her BMI is 29, and in the IAP BMI chart, she's above the 27 adult equivalent. So my question is, what is the appropriate next step? This girl needs thyroxine replacement. You would do a thyroid ultrasound. You would advise lifestyle modifications and probably repeat thyroid function after 3 months. You want to evaluate for other pathological causes of obesity. Your time starts now, 10 seconds. This is question number 8. You can mark the choices, whether it's A, B, or C accordingly. If you have decided on the choice, I'm moving on to the next question. Question number 9. A 3-year, 9-month-old boy with pubic hair, with complaints of pubic hair and penile enlargement. And father says he's taller than his 5-year-old elder brother. His weight is 17 kg, height is 117 centimeter. MPH is quite good, 171 centimeter. His SMR staging, he has pubic hair, P2. His stretched penile length is 7 centimeter. Testicular volume is 4 to 5 ml. And his pubertal hormone levels are in the pubertal range. So I'll just quickly take you through the growth chart. You can see the weight centile, and this is the height centile, pretty high up. And sorry. So what is the most important next step? Would you do an ultrasound of the testis? Would you do an MRI of the brain? Would you want to evaluate a genetic evaluation for genetic causes of precocious puberty? Or would you want to start GnRH analogs at the earliest, considering the pubertal hormone values? So your time starts now. Question number 9. Moving on to the 10th question. This is the last question. This is a 7-year, 4-month-old girl. Mother complains that she has attained menarche 6 months back. She has been noted to be short. She has breast enlargement for last 2 years. She has some intermittent abdominal pain. So she has already come with an ultrasound of the pelvis. And on examination, you find that she has sallow complexion with dry skin. And her weight is 21, height is 102, MPH is 153. It is marked in the growth chart you're seeing on the screen. Her sexual maturity rating is B3, A1, and P1. That is, there is no axillary or pubic hair. She has breast enlargement with menarche. You can see the growth chart here. Her weight centile is here, and her height centile is below the 3rd centile, where her mid-parental centile is at the 25th centile. So I said she has intermittent abdominal pain with menarche. So this is a precocious puberty that is happening. So she has already come to you with an ultrasound of the pelvis and MRI of the brain. So this is her ultrasound pelvis that is showing ovarian cyst, a very large ovarian cyst. And her MRI brain, you can see a homogeneous enlargement of the pituitary. You can see a pituitary mass there. My question is, what is the next appropriate step for this child? Would you do a surgery? Would you want to do an ovarian cystectomy? Would you want to check the thyroid function test and thyroid imaging? Would you want to do an immediate neurosurgical intervention for the pituitary mass? Or would you want to start GnRH analogs straight away for benefit of height gain? Question number 10. I hope you have finished answering the 10th question. These are the answers. So shall I go to the explanation of each?
I think so. You start from the beginning and explain each.
Yeah. So the first question, as you have seen, this is a girl who has come with short stature. When she's making a clenched fist, you can see the head of the metacarpals clearly here, while the fourth head of the metacarpal, you see a dimple there. So that is classically called as the dimple sign or the knuckle sign. And the corresponding X-rays, you can see a short fourth and fifth metacarpal bone. So in the X-ray, this is classically called as the Archibald's metacarpal sign. How do you assess that? If you draw a tangential line, tangential line across the heads of the metacarpal, fourth and fifth, normally this would pass distal to the head of the third metacarpal. But here you can see this is intersecting the head of the third metacarpal. This is a positive metacarpal sign, and this can be seen in certain conditions like Turner syndrome, pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, and we all should know that it can be seen as a normal variant. For example, you might have seen in the normal people around, it can be running in a 2 or 3 generations without short stature, then it is probably normal. But with short stature, definitely you will have to rule out the other conditions which I mentioned, like Turner syndrome, pseudo-hypoparathyroidism. So it's very important to look for a dimple sign or knuckle sign in a child who's coming to you with a short stature. So this is otherwise called brachymetacarpals. This could be associated with a short metatarsals also. This is called brachymetarsal. So these are the common causes: Turner syndrome, pseudo-hypoparathyroidism, and around it could be present as a normal variant around 2 to 4% of the population. So the second question, this is a 7-year-old boy with short stature with a history of recurrent hypoglycemia. So what is the finding in the oral cavity? What you're seeing is a solitary upper central or a single upper central incisor. So this is a midline defect, which could classically point to the presence of a hypopituitarism. So all these are causes of short stature, but definitely you will start evaluating for hypopituitarism, whether it's associated hypothyroidism, growth hormone deficiency, and other pituitary hormone deficiency. Recurrent hypoglycemia could be a manifestation of the pituitary hormone deficit. So I just want to all postgraduates to be aware of the midline defects that you should be looking for in a case of short stature. Starting from head to foot, it is the absence of septum pellucidum or corpus callosum, which is classically seen in the septo-optic dysplasia, where you have an absent septum pellucidum, optic nerve hypoplasia, and pituitary hormone deficiencies associated with pituitary hypoplasia, holoprosencephaly, a cleft lip and cleft palate, and the single solitary median maxillary central incisor, bifid uvula, micropenis. These are all the midline defects which could be associated with hypopituitarism. Going on to the third case, a clinical clue to short stature. As we also saw, this is a term SGA baby, birth weight of 2.1 kg. We all know that SGA babies require proper endocrine monitoring, especially from 2 years of age, because they have high chance for growth failure. But this is a condition, a prototype of SGA, which all pediatricians should be aware of. This child has a history of feeding difficulty, triangular facies, small jaw, and classical clinodactyly. And the answer is Russell-Silver syndrome or Silver-Russell syndrome. So it's a prototype of SGA with certain specific features. There's a clinical scoring system, and it is a genetic condition. It is characterized by prenatal and postnatal growth failure, characteristic facial features, body asymmetry, a relative large-sized head compared to the body, and prominent forehead and feeding difficulty. Coming to the question on anthropometry, the constant which is added to parents' height in mid-parental height calculation. The constant is 13 centimeter. As Dr. Warman was mentioning, mid-parental height is calculated by adding father's height plus mother's height plus 13 the whole divided by 2, and for boys, and minus 13 the whole divided. Why this constant? That is the difference between, in any population, the difference between an average man's height and a woman's height is 13 centimeter. That's how this constant comes. The third percentile is equivalent to which Z score? Roughly it is minus 2 Z score. So this would be the answer. And at birth, the upper segment to lower segment ratio, I'm sure you must have got it right. It is 1.7. About the body proportions, again, Vaman sir was beautifully mentioning it. So the upper segment, lower segment ratio at birth is 1.7. Roughly by 3 years, it is 1.3. And usually by around 7 years, upper segment and lower segment becomes equal, that it is 1. So, and if you would have listened to sir's talk, you would have understood better than upper segment, lower segment ratio, the accurate measurement of proportions would be a sitting height. Height velocity below the following percentile is abnormal. The answer is 25th centile. We all know height below 3rd centile is abnormal in a growth chart. So the height velocity is a more accurate measurement. For example, if you're monitoring certain growth disorders, it would be more useful. So even if the height is above the 3rd centile, a height velocity which is persistently below the 25th centile, definitely it warrants evaluation. Now, the question based on the growth chart. This is a obese kid who's come with an elevated TSH. Thyroid antibodies are negative. So I just want you to concentrate on this growth chart. The weight is way above the 97th centile. The height is also in the higher centiles, way above the mid-parental centile. So this is a child who has a accelerated growth velocity, both height and weight, with a elevated BMI above the 27 adult equivalent. So I just want to explain, there is a chance of transient TSH elevation in obese children due to the peripheral thyroid resistance, and also leptin has a role. Leptin increases the transcription of TRH, which could increase the TSH. There is a little bit of peripheral thyroid resistance which could happen. So that could be the reason, but that does not always mean that there could not be any associated thyroid illness. So it's very important to monitor the child, especially if the TSH is less than 10. This child can be monitored, ask for a lifestyle modification, and you can follow, repeat the thyroid function after 3 months. So the answer is lifestyle modification and repeat thyroid function, especially because there is no goiter and the thyroid antibodies are negative. So there is an entity called hyperthyrotropinemia or elevated TSH associated with obesity, which is due to peripheral thyroid hormone resistance, but rarely it could be associated with autoimmune thyroiditis. The child definitely needs a serial follow-up of thyroid function test. So the obesity associated hyperthyrotropinemia, it may not be causing the weight gain. Actually, it is a consequence of the weight gain. Question number 9. This is a 3-year, 9-month-old boy with precocious puberty. And the bone age was 7 years, testicular volume was pubertal, and all the hormones were in the pubertal range. If you look at this growth chart, you can see the height is way above the 97th centile and above the MPH. So this is a central precocious puberty in a boy. So what is the most important next step? Is it an ultrasound testis, MRI brain, genetic evaluation, or starting GnRH analog? So before the decision on GnRH analog, definitely we want to find out the etiology. And as all of us know, in boys, 2/3 of causes for central precocious puberty is organic, and definitely you need to go ahead with the MRI brain. And hypothalamic hematomas are the commonest tumors causing central precocious puberty. So the answer is MRI brain. When would you do an ultrasound testis? You have an asymmetric testicular volume, especially in a peripheral precocious puberty, you may have to do. Genetic evaluation is not needed. Starting GnRH analogs probably after establishing the cause. The last question, this is again a precocious puberty girl, but I want all of you to look at this growth chart. Usually in precocious puberty, we expect a height acceleration, a bone age acceleration. Here we can see that the height is way below the 3rd centile. So whenever a child presents with precocious puberty with the growth failure, always think about hypothyroidism. So this child has a discordant puberty. The child has breast enlargement. So usual progression of puberty is from breast enlargement, pubic hair and then menarche. Here, the pubic hair is absent. It is, and the breast stage is 3. So a discordant puberty with a growth failure always points towards hypothyroidism. What about these investigations? So usually when it is a chronic hypothyroidism because of the excessive TSH elevation and the biochemical similarity with FSH, this TSH can go and stimulate the FSH receptor and increase estrogen and produce ovarian cyst. So many a times it is misdiagnosed and child may undergo surgery. And also the MRI brain for a precocious puberty showed a pituitary enlargement. This is because of the thyrotrope hyperplasia. Because the thyroid hormones are very low, the pituitary enlarges because of the thyrotrope hyperplasia, and the excessive TSH happens because of that. So the treatment for this is a simple administration of thyroxine. Everything reverts, even this pituitary enlargement reverts. So there is no need for an ovarian cystectomy or neurosurgical intervention or starting GnRH analog. Check the thyroid function test and do a thyroid imaging. So we did that. We found the free T4 was 0.4. TSH was 1200. TPO was very much elevated. This is an autoimmune thyroiditis. In this condition, where the TSH goes and stimulates the FSH receptor, producing a peripheral pseudo-precocious puberty, is called von Wig-Grumbach syndrome. It reverts very well with administration of thyroxine. Thank you.
Thank you, Dr. Parvati. Fantastic quiz questions. Johnny, can you tell us who the winner is?
Yeah, I mean, I'm extremely happy to announce that our messages have really gone through, because this time we have really tough competition on the quiz. When many of them got the correct answers very quickly. And however, we got only one winner as always. So Dr. Savida has won the quiz with 8 marks correctly, and she got the highest marks on the quiz. So Dr. Savida, can you please give your contact number so that we can send you the certificate?
And
so
where
Dr.
you're
Savida,
from, and where you're from too.
Yeah, where are you from and your contact numbers where you can. So Dr. Savida, congratulations, Dr. Savida, for winning this quiz. Yeah.
Dr. Pramod, can you put my video on? Johnny, you can do that.
Yeah, let me see. Ask to start video. Yeah, I've done.
You have to start your own video, sir.
I have asked you to start your video.
now. Yeah. Okay.
Yeah, congratulations. Yeah, I got your number. So you're from SAT Toronto. Very good.
Very good. So that's, what is she doing there?
Yeah,
PNB?
Savida, can you unmute yourself or you can you write your...
Must be Dr. Riaz's postgraduate. Dr. Riaz?
Must be.
Yes, she's a good student.
Very good. Anyway, good. So that's a excellent session. Dr. Vaman, can you show yourself? We'd like to thank all the speakers. It was an excellent session. I think we enjoyed every bit of it, and we are so happy to have you, Dr. Vaman, for our session. You've done such a lot of work in this area, and we were just, all the endocrinologists in Kerala wanted you as the speaker here for this program, and Dr. Parvati was so insistent that Dr. Vaman be our lead discussant, and you did a great job. I wish you all the best in all that you do in future, because you've got lots to do. I think you have to do something about the government, the health services taking up these. I think we'll have much more effective health services if growth monitoring is done in the government service also. I think you must help IAP to do that. I'd also like to thank Dr. Riaz, Dr. Abraham, Paulos, and Dr. Parvati for this presentation. It was excellent. I have no words to explain it. I request Dr. Johnny to say the vote of thanks.
So on behalf of IAP Cochin and IAP Kerala, I thank you all for attending this excellent presentation on lessons from growth charts.